Hello students, welcome to Distinction Learning Platform, and on this platform you find revisions, expansion to difficult topics, you find quizzes, tests, a lot of stuff. So before we begin our lessons, make sure that you subscribe so that you can be updated with all upcoming videos, and don't forget to like the video. Okay, in this video we're talking about what CHF, which is congestive heart failure. Okay, and remember that congestive heart failure is under cardiovascular diseases. So let's talk about congestive heart failure. Congestive heart failure is a very serious disease because it affects about 26 million globally. It has just estimated like that. And also, if you look at the prevalence of congestive heart failure, according to the age it's in less than 50 years, it's affect about what 1% approximately. And if you talk about 60 to 70 years, it's affect about what? It's affect about 5 to 10%. And greater than what 80 years, it's affect about what 10 to 20%. Very important to take note of that. And remember that in most of the countries, including in Zambia, it has been estimated that it affects what? It's going to affect about 9 to 12% of population. And if you look at congestive heart failure, if you look at also at the gender, if you look at the female, the males they are going to develop what? Systolic heart failure, where the heart fails to contract and fails to what? Meet the body what? Demands. Then what else? If you talk about the females they are going to develop what we call diastolic heart failure. Don't worry, we're going to look at the classification of what? Congestive heart failure. Okay, since we know the introduction of congestive heart failure, what is congestive heart failure, or what is heart failure? Heart failure basically is where the heart fails what? To pump enough blood to meet the body what? Demand. So that's a very important simpler definition of heart failure. So what are we saying? Heart failure is what? Failure of, so we're just simply saying failure of the heart to pump enough blood, enough what? Blood to meet the body demands. Okay, that is what we call heart failure. The moment the heart fails to pump enough blood to meet the body demand or metabolic demand, basically the body is experiencing what? Heart failure, or sometimes called congestive what? Heart failure. Okay, so what about the percentage? So what did I say about the prevalence? So we said it affects about what? 26 million of people globally. That is globally. Okay, this is what I said. Okay, and it's going to affect males and females. For males, they're going to have what? Systolic heart failure. For females, they're going to have what? Diastolic heart failure, due to some certain reasons that I'll talk about for. But in advance, if you talk about why males develop systolic heart failure, it's because of what? Alcohol intake and also smoking. Those they are going to predispose someone to have systolic heart failure. And why females they are going to have diastolic heart failure is because of what? The hormones that they produce, estrogen stimulation there, and some other factors as well, maybe pregnancy or other things. Okay. Now, how can you classify CHF or congestive heart failure? How can you classify? So you can classify CHF based on different things or varieties. So what is the first important part? The first important part is what? Based on the what? The side of the heart affected. So based on the what? Side of the heart. Okay, let's just say capital letter H, which is heart. It can be what? Right heart. It can be what? It can be right heart failure or left heart failure. So it can be, the first one is what? Can be left heart failure. Okay, left heart failure. What else? It can also be what? Right heart failure. And what else? It can also be, maybe it can involve both ventricles, biventricular what? Heart failure. Okay, it can involve what? Both ventricles. So according to the side of the heart affected, it can be further classified into what? 3 parts. The first one is left heart failure. where the left side has been affected and failing to pump enough blood to meet the body demand. Right heart failure, biventricular heart failure, where now both the left side and the right side, they are failing to pump enough blood to meet the body metabolic demand. And we'll talk about the causes of this. Don't worry, under the causes and the pathophysiology, why someone can develop heart failure. Okay. Now let's go to another one. Based on what? Another one. Let's talk about based on ejection fraction. So based on ejection fraction. So based on ejection fraction, what is ejection fraction? So before we go any further, we need to talk about what it means when you say ejection fraction. So what is ejection fraction? So ejection fraction is just the amount of blood that's going to be pumped out per ventricle, which is from each ventricle per beat. So what is the ejection fraction? It's the amount of blood pumped out from each ventricle per beat. Okay, not per minute, but per beat, and it has to be expressed in percentage. Very, very important part, because you need to understand ejection fraction. If you understand it, you are going to understand something about pathophysiology, because there is heart failure with reduced ejection fraction, and there is heart failure with preserved ejection fraction. So we need to understand that. Now the question is, what is the normal ejection fraction in the body? So the normal ejection fraction ranges. So normal ejection fraction is is about starting from 50% to 70%. Outside this range is going to be considered abnormal. Okay. Now, what is the number that we consider that someone is having reduced ejection fraction? We are going to consider it as less than 40%. Okay. So if someone you check, then they have ejection fraction less than 40%, then you are going to say, okay, now they are experiencing heart failure with reduced ejection fraction. Okay. So now, how can you classify based on this ejection fraction? So we can say, if the range is greater than 50, or is in this range, which is let's just say greater than 50. So if the range is if the ejection fraction is greater than 50, okay, if it is greater than 50, you're going to say it is heart failure, okay, heart failure with preserved ejection fraction, okay. Preserved ejection fraction. Let's just say PR, preserved ejection fraction. If it is greater than 50, but others they use as low as greater than 40%. But for me, or for us, we're going to use greater than 50%, because there is also another way you can classify heart failure apart from that. So there's also another one, less than 40%. We are saying this is now less than 40%. This is heart failure. Okay, this is heart failure. Okay, heart failure with reduced the ejection fraction. Reduce the ejection fraction. Okay, HFrEF. Okay, this is heart failure with reduced ejection fraction. But there is also another one. Now the question is, what about starting from 40 to 40 to 49, because there is this also range up to 50. So what about 40 to 49? What is this? This is also heart failure, but this is mild heart failure with mild reduced ejection fraction. So this is now heart failure. Okay, this is heart failure with mild reduced ejection fraction. Reduced ejection fraction. This is okay. There are three classifications based on ejection fraction. So less than 40%, that is the heart failure with reduced ejection fraction. Okay. Then what about 40 to 49? Okay, that is mild reduced ejection fraction, heart failure. Then what about greater than 50? Greater than 50%, then that would be preserved heart failure with preserved ejection fraction. Boom, boom. That is very, very simple to understand. Okay, let's go to another classification. What is the other classification? So the other classification will be based on what? So other classification will be based on output, which is the cardiac output. So let's just talk about the cardiac what? Output. Okay. So the other classification will be what? Based on the cardiac output. Okay. Cardiac output. What is cardiac output? Cardiac output is the amount of blood that's going to be pumped out of the heart per minute. What is the normal cardiac output? The normal cardiac output per minute is what? 5 mils per minute. Or 5 liters per minute, sorry. And also the other range that they use is 4 liters per minute to 8 liters per minute. So that is the other range that they use. But basically the average is what? 5 liters per minute. Now, based on that, there will be low cardiac output heart failure and high cardiac output heart failure, which we'll talk about that. So what is the first classification? The first one is what? Someone having low cardiac output. Okay, let's just say, instead of writing low, so let's just say, let's use this arrow. Low cardiac output what? Heart failure. Okay, low cardiac output heart failure. Okay, which is the most common. So this one is the what? Most common. So this is the most common type. Then there's also the one that I talked about, the high output cardiac failure. High output cardiac failure. Okay, high output cardiac failure. This is what? Rare. We'll talk about why someone can have what? High output cardiac failure and what it means according to the what? Pathophysiology. Okay. Then what else? So there are a lot of classification that we need to talk about. Okay. What else? So let's talk about the two last ones. So this one based on what? The last one or the second last, based on what? Pathophysiology. So based on what? Pathophysiology. So based on pathophysiology, which we'll talk about here, okay, we'll understand more on that. Okay, based on pathophysiology, what is that? Okay, based on pathophysiology, if you look at that, it will be based on what? Systolic and also what? Diastolic. Okay, so it will be systolic heart failure and what? Diastolic heart failure. So what are we saying? So based on the pathophysiology, what are we saying? It will be based on what? We are saying it will be based on systolic. Okay, so we're going to say systolic heart failure. Okay, and there will be what? Diastolic heart failure. Okay, so that is based on the what? Pathophysiology. There will be systolic heart failure and the diastolic heart failure. So what is systole? Systole basically is just the contraction of what? Myocardium. Okay, that is responsible to what? For someone to have what? Stroke volume. So what is systole? Basically just talks about what? The contraction of myocardium. Diastole basically just talks about what? The feeding in of the what? The chambers of the heart. Okay, whether the atrium or the what? The ventricles. That is diastole. Now if there is no contraction there, then someone is having systolic heart failure. If there is reduced feeding, then that would be what? Diastolic heart failure. That is based on the what? Pathophysiology. Another important one which I'll write here, another classification which you are going to be asked, because the last classification that I'll talk about is the one that they're going to what? Ask you. Very, very important one. Okay, and it's the one that they use when it comes to what? Treatment of congestive heart failure. Okay, so there's this one, this classification. There is also this one, this classification, NY. That is NYHA. So that is New York Heart Failure Association. Okay, so this one is a very, very important clinical classification. It is further categorized into what? There is a class 1, class 2, class 3, and what? Class 4. So you need to know the classes because treatment will depend on each class. So for some people having class 1 and class 2, they are going to have what? Different treatment modalities. Class 3, class 4, they are going to have what? Different treatment modality. So let's talk about the first one. What is class 1? Okay. So let's say class 1. So class 1, what are they going to see? If you are class 1, if you have class 1, they are going to have what? They are going to have normal what? There will be no limitation. So there is no limitation to physical exercise. Basically, those ordinary exercise or ordinary activities that we do, there will be no physical limitation. So what are you saying about class 1? So those people with heart failure, but with no what? Limitation. No limitation to what? Physical activities or ordinary activities that we do. Okay, unless maybe the activities is not ordinary, then they will start showing what? Symptom. But normal physical activities that we do, they are going to show no limitation. There will be no symptoms of what? Heart failure. So there is also class 2. Okay, now for class 2, there will be what? There will be now, instead of no limitation, there will be what? Slight. Okay, slight what? Limitation. Limitation to what? Physical exercise. To physical exercise. Okay, there will be slight limitation to physical exercise. Physical activities. Okay, physical activities. So those ordinary activities that we do, there will be slight limitation whenever they are doing that. Okay, class 2 or class 3. What about class 3? Then there will be what? Marked limitation. Okay, marked limitation. So for class 3, there will be what? Marked limitation to what? Physical activities that they do. But these people, if they stop doing those physical activities, then the symptoms will go away. So basically at first they are just okay, but if they start doing something, there will be what? Symptoms that they are going to be observed. Okay. Then the last class is what? Class 4. Class 4 is what? So class 4 basically now, even if they are at rest, there will be what? Limitation. So we're going to say limitation. Okay, even at rest. Even if they are what? They are resting, they will be showing what? Symptom. And this is the end stage of what? Heart failure. Okay, they say stage H. Okay, so that is the end stage of what? Heart failure. Very, very important. And although I said NY, this should be the last classification, there is also a classification according to what? Onset. So we can write that. So based on what? So classification based on what? Based on onset. Okay. So there is also classification based on what? Onset. What is the first one? We know that if it is based on onset, we are going to say there will be what? Acute heart failure. Okay. Acute heart failure. Okay. Where the heart is failing acutely. Okay. What else? There will be if it is acute, there will be what? Chronic heart failure. Then what else? There will be the last one. There will be acute heart failure superimposed on what? Chronic heart failure. So there is what? Acute decomposition of what? Heart, whilst they are having what? Chronic heart failure. So what I simply mean that they are having chronic heart failure, but on top of having chronic heart failure, then they develop what? Acute symptoms of what? Heart failure. So what is that? So we're saying acute heart failure superimposed on what? Chronic. So acute heart failure superimposed on chronic CHF. So chronic heart failure. So this is chronic heart failure, not congestive heart failure. So chronic heart failure. So acute heart failure superimposed on what? Chronic heart failure. So that is the other classification that you need to know. Okay, but there are also other classifications like non-congestive heart failure, congestive. There are a lot of classifications. So this is the most important classification that you need to know from now on. Now, since we've understood this, now the question is that you can ask is what could cause someone to develop heart failure? What could be the main reason why someone developing heart failure? Okay, and we talked about the occurrence of that. Now, what could be the problem for that? So we'll talk about the causes and pathophysiology on how heart failure can develop like that. Okay, we'll start with this one and also this one. Okay, now if you look at this one, this is the heart. Okay, this is the heart, and basically this heart is undergoing what? heart failure. So let us write that one. So this middle heart is developing into what? Heart failure. Okay, it is developing into heart failure. So remember that it can be either right-sided heart failure and also left-sided heart failure. But on this one, it will be based on a certain classification that we talked about. It will be based on what? Based on the pathophysiology, basically systolic heart failure and what? The diastolic heart failure. So we're going to categorize this pathophysiological type of what? Heart failure into what? Systolic heart failure and what? Diastolic heart failure, so that we can further understand it. So what are we saying? So we are saying here, we are going to, so from this side, we are going to say, okay, these people are developing systolic what? Heart failure. From this side, systolic heart failure. Okay, this is systolic heart failure. Then from the other side, they are developing what? Diastolic what? Heart failure. Remember, systolic heart failure is common in males, and diastolic heart failure is common in what? Females. Okay, so what is systolic heart failure? What did we say? These muscles of the heart, they are failing what? To contract to meet the what? The body demand. To meet the body what? Demand. So, but what about diastolic? It's the feeding what? It's a feeding problem. So what are we saying about systolic heart failure? We are saying that it's a problem of what? Contraction. There is what? Reduce the contraction. So here let's say contraction of the heart or systole of the heart is what? Reduced. Then what about diastolic heart failure? Is what? Reduced what? Feeding. Okay. Reduced the feeding. Sometimes you say that feeding should be talked about under preload. So reduced preload like that. We'll talk about that. Okay. So let's start from this side. Now, the question is, what could cause reduced contraction? Why the heart is not contracting? What could be the main cause? So we'll start with the most common cause of what? Reduced contractility. Okay, which is one of the most cause of systolic heart failure. What is that? What is the first one? The first one is when someone is having ischemic heart disease. Basically, a good example of one of the important ischemic heart disease is what? Myocardial infarction, MI. Okay, whether STEMI or non-STEMI. So basically, they're just having what? Myocardial infarction. Myocardial infarction is the most common cause of what? Systolic heart failure. Very, very important to note that. Okay. Apart from that, there's also another what? Another cause of what? Reduced contractility. There will be what? Another common cause, that is what? Dilated cardiomyopathy. Remember that cardiomyopathies, we'll talk about them, the different types of cardiomyopathy. Okay, we'll talk about hypertrophic cardiomyopathy, dilated cardiomyopathy, restrictive cardiomyopathy. We'll talk about them in the other video. But the most common cause of the reduced contractility is what? Whether from the right side or from the left side, is what? Dilated cardiomyopathy. Okay, so what are we saying? We're saying DCM, dilated what? Dilated cardiomyopathy. Also, most of the what? Common cause. What else? Another one, there will be a lot. So also, like if we have some valvular diseases, because rheumatic heart disease is one of the disease that can cause heart disease. Heart diseases or valvular diseases like that. So rheumatic heart disease is the one that's going to affect the valves of the heart, and it's also one of the most common cause of what? Systolic heart failure. So now let's try to categorize that. So what is that disease that can cause systolic heart failure under valvular disease or rheumatic heart disease? We're going to call it aortic regurgitation and what? Mitral regurgitation. So what are we saying here? So it's either A stand for aortic, or M stand for what? Mitral, then R stand for what? Regurgitation. So regurgitation basically is what? The valves are not competent enough, whereby they can't close. Then there will be what? Backflow of blood in the heart, because the valves are what? Incompetent. They are what? They are destroyed like that. Okay, that can also cause what? Reduced contraction as well. Sometimes chronic hypertension can also cause what? Can also cause systolic heart failure. Also here it can cause reduced feeding as well. Okay, so now what is the other one? The other one is what? Myocarditis. Myocarditis. So the other important disease that can cause reduced contraction is what? Myocarditis. Basically, we'll just talk about the 4 most common causes of what? Systolic heart failure. Now let's dive into what? To this side. What are the causes of reduced feeding here? What are the most common causes of reduced feeding? The first one is what? Chronic hypertension. Okay. So we say this is the most common cause of reduced feeding. Chronic what? Hypertension. That's the first cause. Okay. Chronic hypertension. What is the other one? Okay. The other one is remember that here we talked about the dilated cardiomyopathy. That side we'll talk about what? That is restrictive what? Hypertrophic cardiomyopathy. So we'll talk about hypertrophic cardiomyopathy. Okay. Hypertrophic cardiomyopathy also, there is also pericarditis also. Okay. There is also pericarditis. Okay. One of the causes of what? Reduced feeding there. Okay. A lot of causes. Now, if you have these causes, okay, if you have these causes now, then what could be the result? So let's start from here. If you have these causes, there is reduced contractility here. So let's talk about this side. So this side, either from the right side or from the left side, these heart muscles, they are being destroyed because of what? These common causes, and the amount of blood that is coming out is what? Reduced. Okay, so what are we saying? So the amount of blood that has to come out because there is reduced contraction is going to be what? Reduced. What is that? Reduced what? Cardiac output. So basically from this side there will be what? Reduced what? Cardiac output. If you are having reduced cardiac output, okay, if you are having reduced cardiac output due to what? This reduced contraction, then basically you are going to have what? Reduced ejection fraction. So here you are going to have what? Reduced ejection what? Fraction. So what could be the result? Because you are reducing the contraction there, then you are going to have what? Reduced ejection fraction. We talked about the ejection fraction. Ejection fraction is the amount of blood that's going to be pumped out per ventricle in a what? In a single cycle, okay? Or per beat. So reduced ejection fraction. Now, what could be that main category where you are having like heart failure with what? Reduced ejection fraction. So I'm going to say this can present to us what? One of the classification of heart failure as what? Heart failure with what? Reduced ejection what? Fraction. So heart failure with what? Reduced ejection fraction. So that's what we call HFrEF. Okay. So heart failure with reduced ejection fraction. Why are they having reduced ejection fraction? Because they have what? Reduced contraction. If you have reduced contraction, also reduced ejection fraction, what are you going to do to cardiac output, or the amount of blood that you are going to pump out of the heart per minute is going to be what? Reduced. Okay, this is what's going to be present. And remember that HFrEF or reduced ejection fraction, remember that what is the percentage of that? We said the percentage is what? Less than 40%. So these people with this systolic heart failure, they're going to have what? Heart failure with reduced ejection fraction less than what? Less than 40. Let me use pink mark. This one, reduced ejection fraction. Okay, now opposite from this side. Okay, if you look at this side, okay, this side quite alright. The muscles, the contractility is just normal here. Basically, if the contractility is normal, the heart muscles, they are able to pump enough blood out of the what? Out of the heart. Basically, that is what they are going to preserve their ejection fraction. So per beat, the amount of blood that's going to come out is going to be what? Preserved, or it's going to be normal. So these people with diastolic heart failure, they're going to have what? Heart failure with preserved ejection fraction. So heart failure. So these people for diastolic heart failure, they're going to have what? Heart failure with what? Preserved. So let's just use PR. Okay, preserved ejection what? Fraction. Okay, which is what? Which is greater than, so this preserved ejection fraction, we said, we talked about a lot of what percentage. We said from 40 to 49, that is basically the mild reduced ejection fraction. But I said greater than 50%, it has to be now It has to be preserved. So that is preserved. So these people, they're going to have what? At least greater than what? 50. Okay? Greater than what? 50% ejection fraction. Then you're going to say they are preserving their ejection fraction. But other books, they say greater than 40. But the most important information that you need to understand is it has to be what? Greater than what? 50, because the normal range it has to be what? Between 50 to 70. But the question that you can ask is that what about maybe if someone is having ejection fraction greater than 70, is it normal? Is it okay? Oh, quite right. Greater than 70, you might think that it's normal, but it is abnormal. We'll talk about a disease which we call heart failure with what? High output or high output cardiac failure. Those people or those patients, they are going to have what? Very, very high ejection fraction, basically greater than what? 70%. So that is also a very, very bad thing. Okay, you need to understand that as well. Now, but these people, even if they are having ejection fraction greater than 50, doesn't necessarily mean that the cardiac output is normal. No, they're also going to have what? The cardiac output is also low. The reason why is very, very simple. If you look at this heart, if you look at the myocardium here, the myocardium is super dilated. It's very, very thin here. Okay, it's very thin because there is reduced contraction, and the amount of blood that is going out is what reduced, leading to what? Reduced cardiac output. Then what about this side? As you can see, these muscles from the right or either from the left, depending on the what? On the side of the heart tree, that's going to be affected. It's going to be what? Super what? Hypertrophied, because they're going to be thickened ventricles as well. Okay, they're going to be thickened ventricles. If the ventricles are what? Are very, very big. So what's going to happen to the feeding? Okay, what's going to happen to the feeding? Remember that this is the blood that is coming into the heart. If these ventricles are what? Are very, very thick, what do you think the space inside the ventricles and atrium is going to be what? Very, very what? Very, very small. If it is very, very small, if you look at the period is going to be reduced, because the space inside there is what? Reduced. If the space is reduced there, the amount of blood, although it's contracting like that, the contractility is okay. Although it's contracted, the amount of blood that's going to come out will be what? Will be low. Basically, because of what? The amount of blood that went into the heart was what? Also low, because the space was reduced. Basically, if you remove, although the contractility is okay, if you pump out that small amount of blood out of the heart, will be what? It will be less than what? The normal cardiac output. Basically, these also people, they're going to present with what? Low cardiac output. So due to that, they're also going to have what? Low cardiac output. So the result of these things, the result of all these, either systolic heart failure or what? Or diastolic heart failure, what is the most common result? The most common result, the common thing is what? Reduce the cardiac output. Okay, that is the most common thing that you are going to observe. The reduced cardiac output. Now, this reduced cardiac output, let's talk about something. Cardiac output is a very, very important formula that you need to understand. What is that formula? So cardiac output is under what? BP. Okay. So blood pressure, remember that blood pressure is nothing but equal to what? It will depend on what? Cardiac output. You multiply by what? You multiply by what? Systemic vascular what? Resistance. So this is the important form that you need to understand about the measuring of what? BP, because it will also help you to understand these other what? Problem that's going to arise, or the compensated mechanism that's going to arise due to what? Also that formula. Okay. So now here the problem is we're having what? Low cardiac output here. Okay. So the problem here, we are having what? Low cardiac output. Okay. The problem here, we are having what? Low cardiac output. Now the body will try to compensate. So if you have low cardiac output, definitely you're going to reduce the what? The blood pressure. So now what's the body going to do so that the body doesn't go into what? Problem. It will try to correct that initial problem, which is the low cardiac output, by increasing the what? Systemic vascular resistance. Okay, this one. Systemic what? Vascular resistance. Okay, systemic vascular resistance. So we'll talk about on how the body compensates by what? Increasing the what? Systemic vascular resistance by using these two important what? Mechanism. Now let's talk about cardiac output. So here, let's talk about cardiac output here. Okay, so cardiac output, we know that it's the amount of blood that is going to be pumped out of the heart per minute. Okay, now if you remember, cardiac output is definitely, if you look at the formula for the cardiac output, is what? Cardiac output is nothing but equal to, you need to get what? Heart rate, then multiply by what? Stroke what? Volume. This one. Stroke volume basically is that is the amount of blood that's going to be pumped out of the heart per what? Per cycle or per beat. That is what we call stroke volume. Stroke volume, and it's going to depend on what? Three important things. Remember that there will be what? It will depend on the afterload, it will depend on the what? Contractility, and it will depend on the preload. Okay? Very, very important concept to understand. So now, the reason why someone was having cardiac output, to go into details, for someone to have low cardiac output, you need to think about something. Okay, the problem is not the heart rate. If you look at the diastolic what? The diastolic heart failure. The problem is not the heart rate. The problem is what? The stroke volume. Okay. What did I say about the stroke volume? So we said the stroke volume is dependent on what? Contractility. Okay. It's dependent on the what? It's dependent as well as afterload. Okay. Afterload, and the other thing is what? It's going to depend on the preload. Okay. So now the problem for someone to develop systolic heart failure and also diastolic heart failure is because of these two important concepts. It's because of what? The stroke volume. It's because of the stroke volume. The stroke volume will depend on the what? Will depend on the contractility of the heart. The stroke volume will depend on the afterload, and the stroke volume, and also stroke volume will depend on the preload. So now if you talk about now to be more specific, we know that if the stroke volume and the problem was contractility, someone is going to develop what? Systolic heart failure. And if the problem is because of the feeding or the afterload, then the problem will be what? Diastolic heart failure. Now, what is afterload? Afterload is what? It's the amount of the resistance that the ventricle is going to overcome so that it can pump out the blood out of the heart. So the amount of resistance that the ventricle is going to overcome in order to pump out blood from the heart. That is what we call afterload. So anything, if you look at the diastolic heart failure, we said, if you look at hypertension is one of the contributing factor that can increase what? Afterload, or the amount of resistance that is outside the systemic circulation. If there's increase in the afterload, then what's going to happen? Then the heart will start failing to what? If the heart fails to overcome that systemic vascular resistance, or basically that afterload, incrementing the afterload, it will develop into what? Diastolic heart failure by doing what? Hypertrophy and reduce feeding, a lot of what? Factors that you've talked about. Okay, that's about what? Cardiac output. Now, let's talk about something. Now, let's talk about the compensatory mechanism that's going to happen. Now, if someone is going to have low cardiac output, what's going to happen? This low cardiac output is going to activate something very, very important so that the body can try to compensate or try to at least correct something that went wrong in the first place. What is that? Okay, so this low cardiac output, so let's write it here. This low cardiac output is going to activate something from the what? Nervous system, which is the central nervous system. It's going to activate what we call the baroreceptor that are located in the what? Near the bifurcation of the what? Carotid arteries. So those baroreceptors, what do they respond to? They respond to what? Low cardiac output. Definitely low cardiac output, that is what? Low blood pressure. That low blood pressure now is going to activate the baroreceptors in the central nervous system. These baroreceptors, they are going to release certain important what? Neurotransmitters or hormones. What are those two important hormones that we know? Norepinephrine and what? Epinephrine. So these two important what? Hormones, what do? They go to the what? They go to the heart. So this is the compensatory mechanism. It's trying to what? To correct something that went wrong. So it will do by what? It will go to the what? It will go to the heart and act on the what? We know that from the heart, they are what we call beta 1 receptors. So norepinephrine and epinephrine, they go to the beta 1 receptors from the heart and activate those beta 1 receptors, and they're going to, in response, they're going to increase what? Heart rate. Okay, so what's the result going to the heart is to increase the what? Increase the heart rate. Remember, if you increase the heart rate, basically you're going to increase the what? The cardiac output. If you increase the cardiac output, you're going to increase the what? The blood pressure. That is the what? The most important factor that you need to understand. The other thing, they don't just go to the heart, they also go to the what? Blood vessels. They also go to the blood vessels. Okay. Now, what are they going to do from the blood vessels? What they are going to do from the blood vessels? Remember that on the blood vessels, from this side, this is the what? Artery side, and this is the what? The venous what? Side. So on the blood vessels, there are what we call alpha 1 receptors. Also from this side, there are what? Alpha 1 receptors. So this norepinephrine and epinephrine, they are going to squeeze the blood vessels, either from the what? From the artery side or from the venous side. So what will happen if they activate the artery side? They activate the blood vessels from the artery side. What's going to happen? If they activate they squeeze or they constrict the blood vessels from the artery side, what do you think? It will look like that. What do you think to this pressure, that this blood that is coming like that? So there will be like more like there will be resistance. Resistance, what did we say? That is what? Increase in the what? Afterload. So from the artery side, if you squeeze or they constrict the blood vessel from that side, what's the result? The result is what? Increase in the what? Afterload. Okay? Increase in the afterload. Okay? Now, what about from the venous side? If you squeeze alpha 1, so if you activate alpha 1 receptor from the venous side, what's going to happen here? You're going to increase the what? Preload. What is preload? Preload is the amount of blood that's going into the what? The ventricles there, or the heart there. So the amount of blood that is entering into the ventricles is what we call what? Preload. And preload is the one major contributing factors in the stroke volume. If you increase the preload, it's going to increase the what? Stroke volume. If you increase the stroke volume, you're going to increase the what? Cardiac output. If you increase the cardiac output, you're going to increase the what? Blood pressure. So the major compensatory mechanism is make sure that you increase the what? Blood pressure, because normally the blood pressure is what? Low. So that's the first thing. So the reason why these two things happens is like that. Now, you might think that increasing the afterload and increasing the preload, these are very what? They are good things. Sometimes they can also be bad. So let us understand that like that. So let's start with the preload. If we are increasing the preload, quite alright. So let's do the two things here. Quite alright. If you increase the preload, if someone is having diastolic what? Someone is having diastolic heart failure. It was because of the feeding process that was failing. Now you are increasing the preload. It's going to what? Make sure that okay, that feeding process is going to be what? Counteracted. So it will be okay with someone having diastolic heart failure. So here it will be okay with someone having what? Diastolic heart failure. So then someone will be what? Okay. That would be the important what? Sign. Now. What about the other dangerous thing? The other dangerous thing about the preload is what? Is if someone is having what? Is having systolic heart failure. Okay? Diastolic heart failure, someone is going to be okay, because the initial problem was what? Reduced feeding. But if you have systolic heart failure, then you are putting more blood there, because the problem here is not the feeding, the problem is what? Contraction. But you are putting more blood here again. You are putting more blood there. Only the heart muscles, they are not contracting. What do you think is going to happen? It's going to dilate more. And if it's dilate more, basically it's going to what? Worsen the what? The heart failure. So here on systolic heart failure, preload is a very bad thing, because it's going to what? Worsening. It's going to worsen what? This heart failure. So it's going to worsen the what? The heart failure. Okay, it's going to worsen the heart failure. Okay, let's talk about also the afterload as well. Okay, Let's talk about the afterload. Afterload also we'll talk about the two important things. Okay. So the two important things about that. Okay. So let's talk about the diastolic heart failure. Diastolic heart failure. What do you think is going to happen if someone is going to have increased afterload? Increased afterload now, diastolic heart failure, is it going to be okay? No, this one is going to be what? It's going to be very, very bad. So it's more like the opposite. So it's going to worsen. Afterload is going to worsen the what? If you increase the afterload, it's going to worsen the what? It's going to worsen the heart failure. Okay? Then this side, if you look at the systolic heart failure is going to be just what? Okay. So systolic heart failure is going to be what? Okay. 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 It's not going to worsen the systolic heart failure because the primary problem was what? The contraction. Okay. But here, if you talk about the diastolic heart failure, it's going to worsen the diastolic what? Heart failure. The reason why the problem was not what? Here the problem was not what? Was not the contraction. It was what? Feeding process. Okay. So that incrementing the afterload now, the amount of blood the amount of pressure that has to be what? Counteracted by the ventricles has increased. Then it's going to worsen the what? The diastolic what? Heart failure, because diastolic heart failure is because of the what? The feeding, and the afterload is going, if it is incrementing the what? Afterload here, incrementing the afterload to make sure that more blood what? Will start coming back like that. If blood is coming back into the ventricles, then it's going to worsen the what? The diastolic what? Heart failure. So those are the important factors that you need to what? To understand. That's the first thing about what? The CNS, sympathetic nervous system. So here, this is the CNF effect. CNS effect, or sympathetic nervous system what? Effect. Compensatory type. What about this side? So this side, we're talking about what? The kidneys. Okay. So let's talk about the kidneys. How do the kidneys going to react when someone is experiencing whether diastolic heart failure or maybe systolic heart failure? How are they going to help in the compensatory mechanisms? What is the first thing? Remember that this cardiac output, low cardiac output or low blood pressure is going to activate some certain important cells in the kidneys, which we call juxtaglomerular apparatus. So if they activate that, what do they produce? They're going to produce what? Renin. Okay. So due to low cardiac output or blood pressure, then it's going to activate juxtaglomerular apparatus that will produce now renin. Okay. So remember that renin is going to activate something as well, which we know. So renin is going to activate something that we know. Okay. We know that renin is going to activate, which we know. Okay. Angiotensinogen 2, angiotensin. Okay. Angiotensin 1. Then angiotensin 1 will be converted into what? Angiotensin what? Angiotensin 2 by what? ACE. Okay? ACE. Angiotensin converting what? Enzyme is going to convert that one. I remember that now ACE2 is going to have a lot of what effects. The first effect that's going to happen about angiotensin 2 is what? It's going to promote the further production of what? Production of what? Aldosterone from the what? Adrenal glands. So it's going to produce what? It's going to promote the production of what? Aldosterone. Okay. What else? Here now, the other effect is that it's going to have the same effect as what? The norepinephrine and epinephrine on what? Blood what? Vessels. So this AT is going to come on the blood vessels, whether from the artery side or from the what? Venous side. It's going to start doing what? It's going to start vasoconstricting those blood vessels, thereby increasing the what? Afterload, and also increasing the what? The preload. Also having those deleterious factors or mechanisms that we talked about. Okay, it will be just the same. But on the blood vessels, AT2 or angiotensin 2 is not going to act on the what? Alpha-1 receptors. They are going to act on the what? Angiotensin 2 receptors. Very, very important what concept to understand. Now, let's talk about aldosterone. So aldosterone, what does it do? Apart from AT2. So aldosterone, what does it do? This one promote what? It's going to promote sodium and water reabsorption. Very, very important concept to understand. This one, sodium, okay, and what? Water reabsorption back into the what? Into the body. And it's a very, very what dangerous thing to do, because if you absorb more water into the body, okay, what's going to happen? The heart is not what? Pumping enough blood. Then you are putting more blood into the what? More fluid into the what? Into the blood. What's going to happen? Then the result of that is that you are going to what? Have edema, whether peripheral edema or what? Pulmonary edema. The result of sodium and water reabsorption is what? The result of that is what? Edema. Okay, that's the result of that. Now, the last and important thing that you need to talk about is that if the heart is failing, okay, if the heart is failing, it produces two important what? Substances or hormones. So it produces what? If the heart is now failing, apart from this compensatory mechanism, it also produces something that is also what? Important. What does it produce? If the heart is failing, it produces what? ANP and BNP. So it produces as well as what? ANP and what? BNP. ANP, that's natriuretic peptide. BNP, that is brain natriuretic peptide. ANP is produced by what? It is produced by the atria of the heart. BNP, although it's brain, because it was first discovered in the what? In the brain, from the brain, but it is produced by the what? By the ventricles of the what? Of the myocyte, of the heart, I mean. Ventricles of the heart. Or basically the myocyte are the one that produces what? That myocyte of the atria produces ANP. Myocyte of the ventricles produces what? BNP. Now, what is the most important thing about BNP? What do? They are going to what? They are going to promote what? Diuresis. They are going to produce what? Promote what? Diuresis. Basically, this is going to promote the excretion of what? Water and this sodium from the what? From the body, by doing what? Antagonizing what? Antagonizing aldosterone, antagonizing what? Angiotensin 2. So those effects are going to be antagonized by what? BNP and ANP. That's the main reason why most treatment they focus on the what? Increment of the ANP and what? BNP, because it's going to help in the what? Management of what? Heart failure. In the next video, we'll talk about the complication of what? Congestive heart failure.